In healthcare, some of the most critical moments aren't the big dramatic procedures, but the handoffs. Today, we're going to break down one of the most common, yet most delicate of them all, switching a patient from an IV drip to an oral pill. We're going to look at why we do it, what the risks are when that IV stops, and exactly how to pull off a perfect, seamless transition.
All right, so let's set the stage. Picture this. A patient is admitted, they're in a tough spot, and we get them on an IV to deliver medication fast and effectively. But an IV isn't a long-term solution. Once things calm down and the patient is stable, the whole conversation changes. It's time to start thinking about moving from that drip to a simple pill.
And that brings up a really good question, right? If the IV is working, the patient is stable, why on earth would we want to change anything? I mean, why fix what isn't broken? It kind of seems like we're just asking for trouble.
Well, it turns out the reasons for making that switch are actually huge. For starters, it's just plain simpler for everybody. And for the patient, it's way more comfortable. I mean, who wants to be tethered to an IV pole, right? On top of that, it lowers costs, it eases the workload for the hospital staff, and honestly, for any kind of long-term treatment, it is by far the safer and more practical way to go.
But here's the thing. You can't just stop the IV and hand the patient a pill. It's not that simple. There's a hidden danger lurking in that exact moment of transition. To really get it, we have to look at what's happening in the body. I like to call it the kinetic cliff.
Okay, so take a look at this. This comparison really lays out the core of the problem. With an IV, you've got this constant, steady stream of medicine going in. The second you stop it, those drug levels in the blood start to drop immediately. An oral dose is the complete opposite. It takes time to get absorbed, so the drug levels have to build up slowly. You see the challenge, right? One level is falling like a rock, while the other is just starting to climb.
And what's driving that drop? It's a key principle called first-order elimination. Sounds complicated, but it's really not. All it means is the more drug you have in your system, the faster your body works to clear it out. And it's this natural, super efficient clearing process that can send a patient right over that kinetic cliff if we aren't paying close attention.
So what happens if we mess this up, if you don't manage this switch properly? Well, it's pretty straightforward and pretty dangerous. You stop the IV, that first-order elimination kicks into high gear, and the drug concentration in the blood just plummets. All of a sudden, the patient's drug levels dip below that effective therapeutic range, and their original condition could come roaring back.
So how do we avoid that? How do we build a bridge across that therapeutic gap and make sure our patient is always protected? It's all about executing the perfect clinical handoff.
And the solution, the golden rule, it really all boils down to one simple thing: timing. To keep that therapeutic effect going without any interruption, that first oral dose has to be given at the exact same time the IV infusion is stopped. Not an hour later, not even a few minutes later, at the same time.
Think of it like this. You're choreographing a perfect exchange. Just as the drug levels from the IV start their downward slide, the levels from the pill are just beginning their upward climb. You're making one curve go down while the other goes up, so they meet right in the middle, keeping the patient safely in that therapeutic zone the whole time.
Let's make this real. Take a look at this example using the drug Theophylline. At hour 0, the moment the IV is stopped, the IV drug level is high, and the oral level is of course 0. But then watch what happens. Over the next 4, 8, 12 hours, as that IV level drops, the oral level rises to take its place. And the crucial part, the total drug level stays perfectly steady right in the therapeutic range. It's a beautiful, seamless handoff.
So what's the magic here? What makes this smooth handoff even possible? A lot of the credit goes to controlled release or extended release formulations. You can think of these pills as tiny, sophisticated delivery systems. They release the medicine slowly and predictably over many hours, basically mimicking the steady drip of an IV and getting rid of those dangerous peaks and troughs.
Now, in the real world, there are a couple of common ways clinicians calculate the right oral dose. But here's the thing, no matter which method you use, there's one non-negotiable rule. The patient must be at a stable, steady state on their IV before you even think about making the switch. You just can't hit a moving target.
All right, so we've covered the science and the strategy, the how of the perfect handoff. Now let's talk about the why. Why does getting this right matter so much? Because the benefits, they ripple out and affect everyone, from the patient to the staff to the whole healthcare system.
And the payoff is absolutely massive. Getting this right means you don't have to constantly monitor drug levels, which is a huge relief. For the patient, the transition is so much smoother and more comfortable, which makes them more likely to stick with their treatment. And critically, you prevent both underdosing, which could let the illness come back, and accidental toxicity. Plus, it just makes the whole process way easier for the nursing staff. It is a win-win-win across the board.
And that really brings us to the big takeaway. We've been focused on this one specific handoff with medication, but the core principle is universal, isn't it? Precise timing, clear communication, and a relentless focus on continuity of care. It really makes you think, where else in patient care, whether it's a shift change between nurses or discharging a patient to go home, can we apply the art of the perfect handoff to make things safer and better for everyone involved?